Okay, great. So then we'll get started. I'll just do a quick context setting and then hand it over to Dr. Anand. Good evening, good afternoon, and good morning, depending on whichever part of the world you are in. This is the first of the series of sessions that we planned this month. Today is the World Spinal Cord Injury Day, and September is the SCI Awareness Month. So we have 8 sessions planned across 4 Sundays. This session has some of the best minds in the rehab space in India for us to learn from and practice. So if you're somebody new to the spinal cord injury space, do not have much of exposure. Until a few decades back, spinal cord injuries were uncommon, and its management was anecdotal, an ailment not to be treated. In other words, they were left to die. Uh, Spinal cord injury results in paralysis. That's the most obvious symptom. This translates to loss of physical movement, loss of bladder, bowel control sensation, and a myriad of other secondary complications like pressure sores, osteoporosis, things like that. Modern science still does not have a cure. And only in the recent few decades, the concept of rehabilitation practices to manage the complications have been developed. And The keyword here is manage. So I think today we are in a scenario where spinal cord injury is badly managed. So on that note, before I pass on to Dr. Anand, I'd like to say that in the YouTube live, please post your comments. In the interest of time, we'll only take a few questions and pass it on to the panelists towards the end of the discussion. And there would also be a translation to Hindi to just summarize. One of our staff would be doing that. So for somebody who does not understand or not well versed with English, there would be some sort of summarizing happening in Hindi. Dr. Anand, over to you.
Thank you, Justin, for having all of us here. Justin was he is the CEO of the Spinal Foundation, the peer organization for persons with spinal cord injury. My name is Anand. I am a consultant in a rehabilitation center in UK, specializing in spinal cord injury management. And I used to work in Velo for many years before I came over here. And we have a panel of specialists in rehabilitation who have a wide experience. And I did a bit of a basic math, and if I'm not wrong, I think among us, I think we have almost 100 years of rehabilitation experience in persons with spinal cord injury. So I'm glad to have Dr. Mrinal Joshi, who is the professor and head of the Department of PMR in SMS Medical College, Jaipur. Dr. Henry, who is a professor of PMR in Christian Medical College, Vellore. Dr. Geeta, who is the professor and head of department in physical and medicine rehabilitation in Stanley Medical College, Chennai. And Mr. Samson Daniel, who is an occupational therapist, and we used to work together in Vellore, and he's now working at the R2D2 Center at IIT Chennai. Thank you all for your time and for your contributions to this discussion. Um, Justin wanted this session to be about the journey we've had so far and the challenges ahead, and how to improve the services for rehabilitation for persons who have spinal cord injury. So I hope to have specific questions and inputs from each of you, and hopefully by the end of the session, we will have a wide range of topics covered related to spinal cord injury management and rehabilitation. Um, like most other anniversaries, this particular day of International Spinal Cord Injury Day, which is commemorated by the ISCOS, I look at it as an opportunity to for us to pause, take stock, and reflect on the progress so far, and a plan for a better future. So, as Justin said, uh, spinal cord injury was anecdotal 5,000 years ago, perhaps. Edwin Smith Papyrus and the often quoted ailment not to be treated was how spinal cord injury was managed for almost 5,000 years, until probably the late 19th century, and First World War changed that. A few insights were gained, and A couple of key figures in the 20th century have helped formulate and standardize management. One was Dr. Donald Munro in the US, and the next was Dr. Ludwig Goodman in Stoke Mandeville in UK. Well, Dr. Munro was the first, and while reading about his principles and philosophies, I was pleasantly surprised to see that most of what we consider as standard rehab inputs currently had already been thought about almost 100 years ago. And I would like to start my the first discussion with Dr. Joshi, if it's all right with you, by quoting Dr. Munro, where he's written in his 90s, 50s book, no matter how extensive the paralysis may be, it is possible to achieve mobility, continence, and the ability to lead a normal social life and work life for most persons with spinal cord injury. And this was written about 70 years ago. So, Dr. Joshi, in your opinion, uh, the Indian scenario of spinal cord injury rehabilitation, especially because your center is among the leading government centers in, as I understand, in rehabilitating persons with spinal cord injury. Where have we come in the last 50, 60 years? And what do you think are the challenges, especially on the later aspect of what Dr. Munro has said, where returning persons with spinal cord injury to lead a near normal life at home and at work? Uh, where do you see us as a specialist in rehabilitation?
Uh, I think that's completely true, as you yourself are very much aware about the work of Dr. Mary Varghese. Now, this we are talking about in 1960s, where she was doing everything on a wheelchair, operating, seeing patients, and helping them out, and also managing herself. The change that I have seen in last 26 years is more of a empowerment, and definitely knowledge has also improved, not only of the doctors but also of the patient, and the accessibility has improved. People have become more sensitive about needs. But another thing that we have to consider, a lot of things in spinal injury are are quite mixed with the economical and the socio psychological uh, web behind the patient. Now, if I see back when I started working in rehab, that was in 1995, almost more than 25 years now. Uh, and since then, the spectrum of patient hasn't changed, but I think their knowledge and their empowerment has changed. Most of the patients that we see today are still the laborers and the agriculture workers, and their awareness about getting a treatment from better rehab center, that has increased, because in those days we used to see patients 1 month or probably 6 months post injury. Now we see them probably 10 days. Most of them we see at the end of 10 days from the day of injury, and rest of the 50% I see within 24 hours, so probably 48 hours of the injury. So those things have changed. Another thing that interestingly has changed is I see more and more patients in follow-ups, because in those days I used to wonder, because you take care of the patient and then they don't come back. Like you see CP patients and you see polio patients, and they would come back for their problems, and you would always wonder where Ajay has gone, whom we was seen, who was a quadriplegic and he was very jovial, and then you find out that he couldn't survive. And I think probably that was not only because of the problem per se, but it was also because of the economical hardship and the lack of knowledge and lack of awareness that there is something good that can come out. And now we see more and more people doing so much good in society. Like you see, just now we have seen Paralympics, like Devinder Jhajaria, Avni. Now she has made a record on a wheelchair. Now these are inspiring figures, and I think they have made some difference, and I think huge difference in the awareness, because now people, because rehab is all about, it is not a one way kind of an intervention. A patient has to be motivated to be in rehab, and you are basically trying to guide them through their journey in the rehab. And if they are motivated, the results are like astonishing. And you can see people joining, like some of our patients have joined Tata, and some of them have joined Reliance, and all those companies they have joined, and they're doing everything. So, and then there is another spectrum where it becomes very hard for us to get these patients even in the indoor gym. So, and you have also seen that in your clinical experience. So I think that has changed. See, as far as the medical intervention is concerned, it always changes. The science changes with time, more evidence is there, more options are there. So that is always there. But I think the major difference that I have seen over the years is education, empowerment, social leadership that has made a difference. The only thing that hasn't changed, unfortunately, is the change of attitude of the funding agencies. Now, that funding agency can be a private setup or it can be a government setup. And as Suranjan always used to say, sometimes you just brush them under the carpet. So those facilities haven't yet come that well as they should have. That's what I feel.
Thank you for your inputs, Dr. Joshi. A couple of points that you mentioned about survival that has improved and about the funding. I'll probably come back to you the second time around and to focus a bit more on those two aspects. Dr. Henry disappeared briefly for a moment, and thanks for coming back. Um, um, I would next like to go to Dr. Geeta, who has worked for many years in Stanley Medical College, which is considered to be among the premier institutions in Tamil Nadu for hand rehabilitation for persons who have hand trauma and who need rehabilitation. And it's been a concerted effort from the surgeons and the rehabilitation physicians over there. And this has been achieved despite there being limitations in the resources in the state funding and this being a state government institution. So my question to you, Dr. Geeta, is in the context of spinal cord injury rehabilitation, what do you think are the limitations in achieving a similar um, status of a center of excellence for spinal injury rehabilitation in state-funded rehabilitation centers? And is there anything we could do to improve? Because the reach for persons with spinal cord injury would be much better if state government hospitals are able to do that. Dr. Geeta, are you able to? I'm not sure if Dr. Geeta is able to hear us. Right. You might have to unmute if you're muted.
I think she's muted, I think.
Okay, so we'll come back to Dr. Geeta later once we have better connectivity there. Then I'll go to Dr. Henry. Dr. Henry, are you with us now? Dr. Henry? I guess we are having difficulties with the technical bits. Dr. Henry, are you able to hear us now?
Now I am able to hear you.
Okay. Yeah, thank you.
Current, yeah. Go ahead.
Dr. Joshi just briefed upon the progresses we have made as a community in terms of rehabilitation for persons with spinal cord injury. And he did mention the work started by Dr. Mary Verghese because she was the pioneer for establishing the first inpatient rehabilitation center in the country in the 1960s. she herself having benefited from the ethos established by Dr. Monroe and Dr. Gutman in the UK. And unlike what those two doctors were able to achieve, uh, in India, we still have institutions which are able to provide some rehab services for persons with spinal cord injury, and they are far and few. And there are, you can probably count with your fingers the number of institutions that are able to provide specialized rehabilitation services. So, as the birthplace of spinal cord injury rehabilitation in India, where do you think Velo has progressed, and in terms of our ability to inspire and achieve better outcomes for patients in the longer, who are not living close by. We do know that there are a few who live within the 100-kilometer radius, and we are able to follow them up regularly. And but there are many who are not able to. So, what in your mind should be the approach as an institution in inspiring better outcomes for persons in the wider region and in the country?
Okay. Thank you very much, Anand, and good evening to everybody. I apologize. Twice I went out because of power shutdown. So if it happens again, just switch on to the next speaker. I'll come on my phone. So yeah, so we have come a long way. Just like the others had said, uh, um, if you look at the data from CMC itself, there has been a publication by Anand and the group, Apurva and the group, which again has showed us that life expectancy has been pretty good for people who have had rehabilitation and who have had some skills training. Now, the challenge now, so if you go back and look at Mary Verghese and the times, those were the challenging times where availability of an infrastructure was not as good. Um, and they did depend on certain technologies for mobility. But things have changed quite a bit, and for the good. Environment is become much more friendlier. People have become much more aware, if not everybody, at least a certain sector. And even patients, they know where to go. There are options for them, and they are able to find out, Google it, and come for rehabilitation. Probably the drive that's really required to push others and get inspired for more new patients, and patients who have not been exposed to rehabilitation before, is peer group. So if you look at it, I mean, if Mary Verghese was there in the therapy hall and I am a patient, definitely it's a totally different ball game, rather than seeing Anand standing there and shouting at 10 people and saying, do this way, don't do this way. So I personally believe peer group interaction makes a huge difference. It influences younger people with newer injuries, and it's one of the best ways to get them out of their vicious cycle of whatever you may call depression, denial, and all those things. That needs to come into many institutions, because nowadays we don't follow a very a biosocial model, and we are only concentrating on the medical bits. We don't get this peer support so often, and that will make a big difference if peer support regularly comes. I'm sure abroad there are centers where people regularly come and talk to the patients and play with the patients and stuff like that. That I think we need it here. Uh, the the other thing I would suggest or think of for better future is, for spinal injuries, the patients and the rehab professionals all to have one body or one umbrella under which they can decide on certain things, sort out some protocols. Each country is different, each culture is different, and what might hold good in the UK or America as a treatment protocol may not really work because of either availability or economic reasons. So, one thing we need desperately is to get all the spinal injury patients documented, get a registry going, so that they have a stronger network, they can reach out faster. And if it's under one umbrella, uh, I think the credibility will be good. um, I think it will be a struggle to reach there as I see it right now. But I think the way forward is to come under one umbrella, come as a single team, and then I think lots is going to change, because then fighting and getting everything for your rights will be much more easier, rather than working in small factions and trying to achieve things.
Thank you. If I can just pick on the one aspect that you mentioned, peers. Uh, I can think of the Rick Hansen model from Canada, where one person with spinal cord injury initiated a big movement, started the Rick Hansen Institution. Now, that institution is funding many organizations in terms of establishing services, collecting data, and they have probably the best spinal cord injury registry in the world. And so, instead of just focusing on persons with spinal cord injury acting as peers, coming in to motivate persons undergoing rehabilitation, do you think there is a greater role for persons with spinal cord injury to be part of the planning process itself? It needs a bit of a cultural change in India in terms of the relationship between healthcare professionals and patient groups. But do you think that's feasible, and why are we not having such uh,
So,
collaboration?
when you think of that, when we are discussing spinal cord injury best practices, as this talk was positioned as, probably all the best practices of whether it is a UTI or a pressure sore or heterotrophic ossification, all is for acute management, acute care. There are some protocols, there are some RCTs, there are some guidelines. That's fine. So what I am thinking of, or what we are talking about now, are people with spinal cord injury in a space where they have finished all that. They are pretty stable, and I know many of our colleagues who had spinal cord injury, who are colleagues now, and they hardly come with any small acute medical issues. Most of them are very stable. So the best practice will stick with the acute phase. When it comes to chronic phase, I think this peer group interaction, people who come in, can definitely take that role. Maybe not as much as they do it in the West, but I'm sure they can also. Probably they need some training, they need some hand holding, because in our country, most of the spinal cord injury persons are not very literate, because most of the injuries are, most common cause we found was fall from heights and RTAs, which happens to mostly laborers and breadwinners. So probably a peer group going at that level of working, where they are organizing, they are writing for funding and all, will be one of the best things. It should be the dream of the Spinal Foundation. Can happen, should happen. Probably there needs a little bit of hand holding and training, because as Indians or Asians, we are not great at documenting, so we are not good at putting it in words and presenting it to the world. We just talk among ourselves, and we forget about that. So yeah, definitely there's a role. They should come in, they should have some training if possible somewhere, and then take it on from there.
Sure. Thank you. Uh, Dr. Geeta, are you able to hear me now?
Yeah, yes. Can you hear me?
Yes, thank you. So, if I can revisit the question I had asked you earlier, where you have had a rich experience in working in Stanley Medical College, which is still a center of excellence among the government institutions, and previously even among the private institutions, in handling persons with severe hand injuries and rehabilitating them. Why are we not having such centers of excellence for conditions like spinal cord injury, which need much intense specialized inputs? And how do you see we progressing from where we are currently?
Oh, thank you, Anand, and thank you, Justin, for including me in this panel. Regarding Stanley, as you said, hand injury has been there for many years, and PMR department itself was under the Department of Hand. So they had all the physiatrists with them, and they also had occupational therapists and physiotherapists, and that's why they were able to do a very good rehab work. Now the PMR department is separate, independent, and it caters to the needs of all the other departments. Okay. And so in future, I think we will be able to establish a spinal cord injury rehab center in Stanley. And another thing is we do have a specialized rehab center in Institute of Rehabilitation, Government Rehabilitation Institute in Kekinada, which is attached to Madras Medical College. So the basic thing which you may be knowing is that we didn't have much of faculty. So
Yeah.
we only had diplomas. Now we have all the diplomas are scrapped, and now we have MD, and we have one more college which is running the MD course in Tamil Nadu. There are only two colleges apart from CMC Velo. I'm saying the government setup. So we do have more MDPMRs coming out, and now the National Medical Council, which is the former MCI, has made it mandatory for PMR department to be there to start MBBS. So this is a very very good move, I think, and I see a good future for the PMR department as well for the rehabilitation of spinal cord injury. It will take a bit more of time, probably another 5 to 10 years. We can have more centers established in government settings because we have students who are being trained in PMR in Madras Medical College and in Hip Hop Medical College, and they come back into the government service. So they are already exposed to spinal cord injury, apart from the other disabled people like amputees and other things. So it's just a matter of time, I think, and I'm very optimistic that soon in government hospitals we will be having better facilities and better rehab for the spinal cord injury.
Sure. Thank you. And I fully agree there. Compared to when I started my training in the mid 2000s, the number of professionals coming out has significantly jumped in Tamil Nadu, and it's a very promising sign. Thank you, Dr. Geeta. Uh, Moving on to Mr. Sampson, who's his riding two horses at the same time in his uh, qualification as an occupational therapist and now working at the R2D2 Center for Research for Rehabilitation at IIT. Samson, my question is more clinical for you, at least for this session. I'm sure you are focusing on the technical bits on the next session. For persons with spinal cord injury, or for that matter, any person who has paralysis of any etiology, the therapists and the nurses are perhaps the professionals who spend the most time together during the acute rehabilitation phase. And often I've had my own friends from therapy who come up with the um, who convey the difficulties faced by persons with spinal cord injury, and who do not have the confidence of conveying that to the physicians, or who don't find the time to do that. Often it comes through the therapist, uh, and but often the focus of the person with spinal cord injury and persons in their family is on cure, recovery of paralysis, improving muscle strength, walking, and the focus is not on, as Dr. Monroe and Dr. Gutman emphasized 100, again, 70, 80 years ago. The focus often is not on improving independence in ADL, returning home on a wheelchair, uh, not needing anyone's assistance, returning to work, engaging in sports. So that is not at least the first thought that comes to the mind of persons with acute spinal cord injury. Where do you think we should change? Who has to change? Is it persons with spine injury? Is it the professionals? Or what do you think should happen for us to change on the whole?
Thank you, Dagan. Is my voice clear and audible?
Yes, it
Okay.
is.
Okay. So this is an interesting question, and this is, I think, perhaps the question which should be addressed at this point of time. Um, in if I'm very specific to India, and I've done most of my work in the southern part of India, from my experience, I've seen this a lot. So when patients come for rehabilitation, maybe in the acute stage or even the rehabilitation stage, they have a particular goal in mind. Either they want to prove something to themselves, like they have to walk, or they have to like regain the bowel and bladder sensation or activities, or they have to prove it to someone else, like their people living in the community or people in the family, that they are not going to be significantly impaired by the health condition. So at some point of time, there needs to be a discussion or there needs to be a negotiation with them, with the persons, with the professionals who spend the most amount of time. As you had mentioned earlier, it will usually be the nurses who come into contact first, and sometimes the therapist. And there is a process of building a relationship, a temporary relationship, and sometimes which can kind of lead to a proper friendship as well. And the relationship becomes very kind of personal also sometimes, and they get to trust what they hear from the professionals whom they feel confident about. So I think the first thing which should be done is, rather than telling them on the face that cure is not possible or recovery is not possible, is to instill hope about getting to a stage where they will be able to resume their activities. I think that is the key. So in occupational therapy, we talk about occupational performance. That means that every person has a particular role to play in the community at a bigger level, in the family at again bigger level, with among two persons, to the persons whom they are caring for, to their pets, to their infrastructure, to the home, to their office, and there are many different roles which we don't often think about. Becomes we are gradually exposed to it day by day, and we learn certain things from other people, and there's a lot of peer interaction going about, and then it becomes like breathing. It becomes an activity which we don't pay much of an attention to. But only when it gets affected, and we think about the most obvious signs, that is not able to walk or not able to perform blood and bowel movements and other things, may seem totally impossible because we are used to such a kind of thing. If you see, probably I'm not sure if it's the right example. I've seen children with paralysis or a chronic condition adapt faster because their ability to learn, or their ability to not recollect previous experiences of how they were doing things, but their ability to kind of focus on what had to be done and focus on what adaptations had to be incorporated is very high compared to adults. Rarely I've seen a person kind of have that acceptance, which is a jargon which you commonly use, saying which tells about a person accepts that I won't be able to walk, or I will be on a wheelchair, I'll be transferring from the bed in a different way. Rarely I've seen, probably one in 100 or one in 50. That is very rare. So I think coming to the point, so the persons who are in coming to the contact person, nurses or the therapist, or it can be any part of the rehabilitation team who spends the most amount of time, should be designated or nominated to kind of guide them, not with their specialty but on a general aspect, to guide the family on what will be the finding the felt need. Again, that is jargon which we use to kind of negotiate between what the person actually wants and what the person actually needs. Oftentimes it goes the other way. Either we do what the person wants, like if the person asks to, the patient asks to be made to walk again, we do that without even considering the significant amount of damage the person is going to get into. Or we go the other way, we kind of we impose our knowledge, or we impose whatever we are learning into them, saying this is the wheelchair you use, and this is how you should be working, and this is how you should. But we are from a holistic rehabilitation point of view. I think it should be a negotiation, and that felt need should be identified, and there should be one person from the rehabilitation team, or maybe two, or maybe three, with whom the patient is very confident, or the patient can trust, who doesn't usually come up with a writing pad and takes notes and gives appearance of somebody who's taking a survey about their health condition. Somebody whom the patient can trust, and the goals can be expressed and negotiated to take them back to their occupational roles. I think that should be the key word here. There are going to be compromises, and that should be told to the patient rather than telling after the surgery the patient will be walking, because that's the idea which most of the patients come up with. So it should not be a surprise that they are going to be on a wheelchair, but day by day, I think it should be conveyed that getting back to their occupational role or whatever they had to do, not achieving something because they are they're a person with paraplegia, or not being able to do something because they have a paraplegia. They should be able to do whatever they like, and we are there to provide the way for that, and we are there to provide a specialty from different forms of rehabilitation support. I think that should be the core idea of rehabilitation, and the peer support plays a huge role in that, because that's something people see in flesh and blood in front of their eyes, and they can be very good example.
Sure. Thank you. So, goal setting, which has to be pragmatic, probably. Yes, I take your point. One or two persons speaking, but I think whoever is rehabilitation is a team effort, and I think all of us should sing from the same sheet. Only then the right information will be conveyed to the patient. Sure. Thank you. Um, I'll now go back to Dr. Joshi, who's done a few research projects, and I understand that you've helped quite a few of your students to do research on spinal cord injury, and there was even a randomized control trial on osteoporosis in spinal cord injury, which got published, and I really appreciate the efforts that you've put in your practice to do research in spinal cord injury. But your publication and a few publications from two or three other institutions, and that's it. We don't have much research happening, which is going to change the way things are being practiced in the Indian scenario. So two aspects to the question: what has facilitated you doing those research projects, and what do you think is limiting such useful and pragmatic research being done more widely? And when I say pragmatic, I know you also are your one of your specialist interests is in cerebral palsy, and then we have specific outcomes such as GMFCS and walking for outcomes for persons with cerebral palsy. But when it comes to spinal injury research, what do we think is a useful outcome? What do we think will be success for spinal cord injury rehabilitation? So how do we tie up this research and being pragmatic? Thank you. You may have to unmute yourself, Dr. Joshi. Thank you.
Okay, so now we have to talk about two parts. One part is doing research. Okay, now being into a teaching institute or academic institute, it put always pressure on the members of the faculty to publish or perish. That is one aspect. And then the second aspect that promotes research is inquisitiveness. And when we see some patients, they improve their neuropathic pain by, say, tricyclic antidepressant, and then the other becomes better by levetiracetam. And then it puts a question in your mind, like, what is happening? What kind of receptor, what kind of pathways are being used? And recently that we are working in, interestingly, into neuropathic pain, because if you see the Western world or the Western publication, their description of pain is totally different what we see in India. And the ability for an Indian patient to endure pain is also different. And that is more of a psychosocial kind of a reason, where pain, addressing a little bit of pain is not too manly, or it's puts you like a weak person. So most of the times people do not complain of mild to moderate pain. It's about the moderate to severe. Then only then they actually tell you that they are suffering because of pain. So these are the interesting aspects. So what I want to say is that both of things are there. One is inquisitiveness towards your patient, towards your symptoms, that drives you to do research in a meaningful way. The other one is that you definitely have to publish to sustain yourself also. The second thing, why we don't see too much research from an Indian context, and I think I did a presentation on this last year when we had some conference in Chennai, and I reviewed the total publication that had happened in last 5 years from different institutes in India, and the best number was from CMC, followed by AIMS, and then um, our institute, and then Jodhpur AIMS. And the number was still very poor. It was not really great. And I think the training that we have been imparted into does not include scientific writing. It does not include biostatistics. It does not include how to do research, how to model research question. And I think that is one of the very important point for us to have this included in the curriculum. Now it should be included in UG and PG. That I don't know because I'm not in a position to make that statement. But that I think is one of the very important point, having background of good biostatistics and the research background, and then how to write in scientific literature. And I think that is why. And the other thing is we do not have a journal. Now, if we have to publish in some journal, you have to find a Western journal. There are not many. I think there is not any journal published by an Indian group in rehab. And that becomes a difficult proposition because the competition is too high when you go to Western, and they have their own priorities. Like recently, we had this experience in the PWD Act of 2018. They have changed the way we measure disability, and there are many flaws that we have seen in our own research. And now it is difficult for us to publish in a Western literature because there it is meaningless because they use American guides, and the 2018 guide is totally meaningless for their readers. So now we don't have our own journal, so we are now finding out where we should send. And a journal should be such that people are actually able to read it and make changes in their clinical practice. So it's challenging. The other question is about the ADLs that you were talking about. And we have just finished, I think it's already being accepted and being published in archives, the SCIM 4 in spinal cord injury patients. And as Samson was telling, we always say to our patient, we live each day and then we think about the next day on the next day. And we take one step at a time. Once we improve the step one, we think about step two. And that is how we usually progress in rehab. And we always say, okay, we do wheelchair transfers, and once we do that, then we talk about wheelies. Once you do wheelie, once you get onto a parallel bar, we talk about standing and balancing, and then we talk about walking in the parallel bar. So there is always goal setting. Rehab is all about goal setting and motivation. But at the end of the day, I'll give you an example. This happened with me, I think, more than, I think now 5-7 years back. Now, there is a big CSR fund which is sponsored by the ICICI Bank, and they have a training center. And there, what they do is they take people with 10th pass background, and they train them for repairing household electrical appliances. They train them for soft office skills, picking up phone, reception, and things like that. Then they also teach them about plumbing, and there is some fourth profession also. And the whole setup is very nice. The industry leaders like Crompton and Greaves and Microsoft people are coming there and training them for all these skills. And I was very excited. And I went there and I talked to them because this is 100% sponsored scheme. The trainee actually has to live there for a month or couple of months. The food is provided, shelter is provided, training is provided, and then they have tie-ups with different companies. So most of them have a short vocation also. The only problem was that was situated in third floor. And then the curbs and all the architectural barriers were so big. And this fellow who was heading it, he was very helpful. He said, sir, we are going to help your patient in this and that. And as I said, that there are so many architectural barriers that either you have to take them with their attendant or you have to change your this hostel structure. And he jumped upon it. And he said, no, sir, we can't do that. It is very difficult for us to help. So now the thing is, now we have to understand the basic problem in our Indian context. The average family income of a common injured spinal cord injury person is 6,000 to 10,000 per month, with a family of 4.5. Usually, the bread earner is the male person who is with you as a paraplegic. He has lost his job. So now sometimes our training in ADL, our training in mobility just loses its meaning. Because at the end of the day, job is important to survive. And I think one of the most important aspect of rehab failure is job. If the guys don't get a job because most of them have to switch. They have to change their job. And we do not have proper vocational training centers. Even there is a big vocational training center in Jaipur, and I went there. This is a government vocational training center. And they are teaching making chairs and candles, and who makes candles and who buys them. These are completely, totally impractical things. So people
Yes.
have not matured. And if Justin is listening, and I think there is lot of communication that has to be done. The vocational training people have to be written a letter. We have to talk to them. Nobody buys those cane chairs now. Everybody buys a plastic chair. So where these people, even if you train them, where they're going to go?
Exactly.
Okay.
Yeah.
And then
So there seems to be a disconnect between what's on offer and what actually will lead to the each person doing what is relevant to their status in the society. Is there anything? I'm particularly aware of the time we are closing to the 1
okay,
hour mark. So are you? Is there anything in particular that you think we can do to improve the community
okay.
reintegration?
That is what I was coming to. So one was that they should have good communication with the government for the upgradation of the vocational training center. Even I talked to the CM then was Vasundhara Raje, and I said, until and unless you have a residential facility within the vocational training center, things will not work for us. The other thing was that there was a scheme there is a separate department now. Previously, there was only one department called as Department of Social Justice and Empowerment. Now there is a separate department called as Disability Affairs under it. And I can tell you with my own interaction, they are very much interested. They are very much interested to do work. But these guys also don't know where they have to go, in which direction. They started a scheme which was called a State Spinal Injury Center, which was 5-6 years back. And you'll be surprised that I was the only taker 7 years back. None of the district hospitals actually applied because even the doctors didn't know that there is such a good scheme where they were giving one time input of 2 crore rupees. So
Okay.
I think these guys have to talk to the Disability Affairs Department. There is lot, and in my own experience with not only with the patient but with the Department of Social Justice and Empowerment, the key to improve, if Justin and everybody, it is empowerment. Until and unless there is an empowerment to the patient about their rights, about the facility that can be provided from them, and there is a lack from our side or the government side or whatever, we cannot improve. So it
Sure.
has to be there. So I think
Sure.
I will just end there.
Sure, thank you. So, matching the needs and the resources in a much wider scale, that has to happen, and hopefully, we will be able to do it in the future. On the same note, if I can go on to Dr. Henry, who is a big proponent of activity, running, getting out, don't stay at home. Dr. Henry, do you believe that getting persons with spinal cord injury onto the sports quite early on in their rehabilitation, getting them to be more active, getting into leisure activities, do you think that's going to, similar to what Ludwig Wittmann did? Do you think that's an important aspect of community rehabilitation, community reintegration?
I think that's absolutely very necessary. Yesterday, I was telling a few therapists that we need to change all our initial training protocols into sports. I mean, Paralympics just got over or getting over. We've won 19 medals this year, far better than the previous years. We are doing pretty well. And in my personal opinion, I have seen spinal injury patients who have been into some kind of sport have done extremely well. My outcome measure for extremely well is don't come to the hospital. As simple as that. They never run into major trouble. I mean, one of small things which can be managed at home or local hospital. So um, I think it's very, very important. Um, Once they start getting out, I mean, even if they're not competing or getting formally trained, if they just get out and do some physical activity, aerobic activity, their skills will improve, their complication chances will come down, whatever it may be. It's a real way forward. And I've had some discussions with some senior spinal cord injury colleagues of us where we have discussed this. I think, and we had a plan of doing something in CMC Vellore because we have the infrastructure for it, space for it, to see how much of therapy can be actually converted to sport. Um, just like Ludwig Guttmann did that in 1948 or whatever, and started with archery. Archery, anybody can start. So we just need some basic stuff. And for the next group of people with technology, and I've had some discussions with bioengineering here also, where um, we have 2 or 3 boys who are pretty good with shot put and javelin, paraplegics on the wheelchair. And the reason they're not able to grow is they don't have place for practice, they don't have support for practice. So that's why I think possibly technology can come in, where they can help these kids or boys or men uh, use technology and become good at whatever sport they are interested in. I think it is very, very fundamental that human movement sport is important. It will definitely make a huge difference in the functional outcomes. Random exercises, gymming, is good, but then it's not physiological, it's not functional. So I think the spinal injury group, I mean, Justin has been a swimmer, Justin has been a shooter, he knows it. We need to focus, we need to think out of the box, we need to change some protocols, bring in a lot of aerobic activities, not gym based or hall based activities. Definitely, I mean, personally I've gone through that, so I can vouch for it.
Sure, thank you. You did mention we should get all these done. So probably the doctors and therapists should set the stage by getting involved in these activities first themselves. Patients will be motivated as well.
Yeah, and probably parallelly there has to be events where so I went for an event last week. It was a synthetic track, and I was just telling Justin that yeah, it's somewhere near you, you should be doing some events there, get some wheelchair guys. But I don't know whether they will allow wheelchairs to go on those tracks and complain and all that. So only when they get together and do an event, there will be more awareness. Next time he will allow them. So we used to have a few wheelchair thing. Unfortunately, because of Corona, we've not had much. But I think public functions, public events, sporting events on wheelchair, off wheelchair is very, very important to get some. Um, Quickly, I'll give you another small example. After Corona, few of I know a CP boy who swims extremely well with only his upper limbs, and he's done 5K in the ocean continuously for 4 hours. And suddenly, people complained that CP children should not be coming to swimming pool because of secretions and this and that and all that. And they were banned from all the swimming pools. Where does this child go? And how can you build your own swimming pool? There are a whole lot of children who are enjoying swimming. So fortunately, yesterday the health minister intervened and he has given permission. So you have to make noise. They did make noise for a couple of months before they reached here. So, and making noise alone in small cohorts does not make sense. We have to get this spinal injury group under one big umbrella and shout out loud. Otherwise, in small factions, we are going to reach nowhere. Even research. I've had some discussions with some of the spinal injury patients. It should come from them. We should make them partners. Then there'll be meaningful research, what they want, not what academically we want, and maybe it doesn't make a big difference in their life. If we have clinical questions from them and they being part of it, brilliant. And the registry. If the registry is there, research India is a gold mine. Name a topic, you can finish it in 6 months.
Yeah, fully agree there, especially with the inputs with my association with the registry initiative, where we are trying to at least enumerate all persons with spinal cord injury in India, and hopefully that will be um, a good resource. You talked about making noise. If I can quickly go to Dr. Geeta about one particularly vulnerable group, women with spinal cord injury. Uh, Generally, spinal cord injury causes significant issues, but women have particular difficulties, especially in terms of bladder management, menstruation, pregnancy. So, what are your thoughts on this, Dr. Geeta?
Uh, yes, Anand. Actually, the number of women who are having spinal cord injury compared to that of men is, I think, it's only around about 20% or 30%. So there are very few compared to men. There are lesser women with paraplegia or quadriplegia, but actually, women are called the weaker sex. But I feel that they are the strongest sex. See, how many patients, how many women paraplegics have come up with questions regarding their menstruation or pregnancy. See, they somehow manage it themselves. So they find a way by themselves and they manage it. Whatever hardship comes, women, especially the Indian women, we are built strong and we are trained from childhood to face difficulties and overcome it. And Henry was talking about technology. I think regarding the bladder management, one of the things which we can advocate for the female paraplegics is the Mitrofanov technique. I think you must be aware of the Mitrofanov thing, where they take the appendix and they make an opening in the abdomen, so they can do the intermittent catheterization through that. So they don't. It is quite difficult for the women to do the catheterization per urethra. They have to use mirror and all that. So this technique, if we have to involve the urologist, and there are a few urologists who are interested in neurogenic bladder. I think we should advocate more of these techniques. So go in for the Mitrofanov surgeries, and we can give this, make this technique available to them. So life will be much more easier for them. And
If I
regarding
can comment there, Dr. Geeta, I think we are running short of time as well. Thanks for your inputs about that. And we've had a few experience with Mitrofanov in Vellore and over here, and it's a bit of a surgical challenge as well in getting to
yes,
access the surgical services. And so, when possible, we try and provide a comprehensive service within our rehab services in most of our centers. And so, hopefully, we will be able to address the needs of women with spinal cord injury, and in future we'll be able to voice for them and facilitate them to come out with their specific concerns. Before signing off, I would like to go to Samson. Samson, we've had discussions about whatever we do, all of us, acute spinal cord injury, surgery, interventions, rehabilitation, sports. Finally, the person has to go back to the community and become part of the community, become a contributing member of the society, a member of the family. How do we measure that, though? What do you think? There are a few scales, but do you think that's sufficient? How do we ensure that community integration is better implemented as part of spine injury rehabilitation?
Um, I think it has to be a very subjective response from the person. There are a few scales which can measure the community integration, but it may or may not apply to everybody in the Indian cultural landscape. But it has to come from the person. Like it can be as simple as listing down whatever they were doing before the spinal injury, and then asking whether they are doing at that same level, and asking about their satisfaction, asking questions about frequency, if they are going to family functions or parties, or going to a salon, for example, as frequent as they would like to be. Then we can see where is the problem. Is the problem on transfer? Is the problem on attitude? Is the problem on the environment which is making them disabled? Or is a problem on some internal reasons, whether they're not feeling good enough to go? So rehabilitation has to be, or the therapeutic techniques or the surgical interventions, everything has to be focused on what we can learn from other persons. So we need to kind of reiterate or practice based on what we learn from. I think when I was working with CMC Velu, there has to be a good habit about monthly home visit to a certain number of patients. There we learn a lot of stuff, how devices are being used, how they are getting integrated community, and other things. There we don't use much of a skills. Everything is like based on what we see, what we hear, and what we understand, and we relate them between what happens in the institution and what happens into the community. It'll be good if it's a very qualitative one. That will be because when we stick to scales, then we might miss on some things. May be a combination, or it has to come from the person's experience. End of the day, it has to be based on what the user is able to do and feel
Sure.
satisfied.
Thank you, Samson, and I think we have come to the end of the session. And thank you, everyone, for your contributions. And I hope this is just the first of the many sessions and interactions we'll have to facilitate better outcomes for persons with spinal cord injury. Thank you very much.
Dr. Anand, thank you so much. Thank you all the panelists. But before we close the session, I want to leave some thought-provoking things for the panelists and for the audience, especially the rehab experts who are part of the audience. So, one to start off with, let me just quote some statistics. According to WHO, we are talking about 15 to 18,000 incidents of spinal cord injury every year. But that said, if you look at the capacity that we have across specialist centers, be it CMC or Savai Mansingh or ISIC or Stanley or any other top centers that can actually handle rehabilitation of spinal cord injury people, we're talking about a capacity of about 3,000 beds. So there is a large part of people who are still out of the healthcare system. I think something needs to be done, and maybe there could be a starting point. That's one. And this also points to the fact that a lot of them are still unaccounted for. They are part of, some kind of acute healthcare access that's happening, or probably not happening at all, or left to die. So accounting for patients has to happen. We are also running a pilot for registry, which should launch pretty soon, but definitely some work there. Secondly, I know we talked about peer movement and being part of it. I think I want to leave a thought here saying peer should be very much part of the rehab design. The way it is designed, center of the rehabilitation, like user-centric rehabilitation programs. We have therapists, we have doctors, we have nurses, we have psychologists, we have bioengineering folks who are part of the design, but peers are not part of, they're not employed as part of the team. I think something needs to be done there, because it becomes an us versus them kind of a conversation, and that needs to stop, and it becomes, all of us. And lastly, sports. I think all of these centers that I pointed out had the potential to be the Stoke Mandeville of India. I think somewhere we did not capitalize on that. So maybe in the future, there is an opportunity there. With those thoughts, thank you so much to the panelists and Dr. Anand for moderating this fantastic session. Uh, I hope I made sense. Thank you so much.
Thank you.
Thank you. Thank you for inviting us. Thank you.
Thank you. So
Thank you, Justin.
we
Thank
do
you.
have the
Thank
next
you.
set of panelists already there. So we'll start off with the next session. While I quoted statistics and I said, how things could be better. What necessarily happens in a rehabilitation program is, it's often one-to-one, where the therapist has to sit with the person with spinal cord injury, or the doctor has to sit with them. Um, and how do we achieve at scale? That becomes a significant problem. One of the best possible tools to achieve a better quality of life at scale is the use of assistive technologies, assistive devices. So we have some experts here who worked in the space of assistive technology. So I'll pass the baton to Shashank, who will introduce himself and the panelists and kickstart the second panel discussion. Thank you so much. Shashank, over to you.
Hi everyone. I hope I'm audible to everyone. Can you get a mic check to just?
Yes, please go ahead.
Hi everyone. Hi speakers, panelists, hosts, and the audience. Thank you very much for joining this panel today. I am extremely honored to be your moderator for this panel, and we have three very important and I'm sorry, there is a power cut on my end, but I'll continue talking. Um, so, uh, so we have three very eminent and three very important speakers who are going to enlighten us about assistive technology, the scope of assistive technology in India, and how we can make the situation of assistive technology in India much better and improve the empowerment of people with disabilities and more importantly, people with spinal cord injuries. So, first, let me introduce myself. I'm Shashank Kallu. I have BTech and Masters in Mechanical Engineering, and I'm currently pursuing my MBA. And I am a person with a spinal cord injury myself. I'm a quadriplegic. I have been one since 2012. And uh, I, I know two of the three panelists today personally, and I'm extremely excited to meet the third panelist for the first time and hear him talk. So, without further ado, let's get started. So, based on 2011 WHO report about disability, uh, you exclude 15% of Earth's population if you don't make your design accessible. So, in fact, the foreword for the 2011 WHO report was written by late Dr. Stephen Hawking, who said, "We have a moral duty to remove the barriers to participation and to invest sufficient funding and expertise to unlock the vast potential of people with disabilities." So, keeping that in mind, uh, coming to India, about two-thirds of the population with disability in India does not have any income, and most of the rest has very low income. Okay. And so India is bound to continue being a low volume market for assistive technology or rehab devices. So unless there is a significant change in this space, or unless there is a significant increase in demand, global players or homegrown startups will not be interested in investing. So this is a great segue to bring up our first speaker for the panel. Um, Please let me introduce you to Vivek Sarda. He's the head of design projects at R2D2 lab at IIT Madras. Vivek Sarda is a graduate from IIT Madras with specialization in product design. His interest for creating impact with work made him start his career in assistive devices. Some of the devices he has worked on include body movement wheelchair, uh, which you probably know as Arise, and standing wheelchair, and Neo Bolt, wheelchair clip-on, Neofly, and customized wheelchair, polycentric prosthetic for knees, easy look orthotic knee, etc. User-centric design forms his core value for product development. His motto is build great products which users love. So, um, Vivek currently heads the design team at R2D2 Center, and his work involves development of devices and assisting various teams in their product development journey. Now, Vivek, my question to you is, how does IIT Madras through R2D2 Lab help bring the barriers of cost and technology down to encourage assistive technology manufacturing and design in India? So, what are the specific issues to India in bringing assistive technology products to market? If you
Eh,
can please pepper in your valuable experience, that would enrich the conversation a lot more. Thank you.
Surely, yeah. Thank you so much. Firstly, thank you so much for inviting us. I'm filling in for Professor Sujata Srinivasan, who could not be over here for personal reason. So, taking this particular thought ahead. So, basically, at R2D2 Lab IIT Madras, our goal is to develop functional and affordable devices. Now, the functional part of it comes when we do a lot of research before we get into any device development. And to make it more affordable, the model what we use is what we call as a grid model, where there is grant, research, industry, and dissemination. where for any device development there is a lot of R&D required, especially when we are talking about any new device development. So the model what we take at R2D2 lab is, for whatever R&D cost is involved, we get a different funding agency to fund the project, so that this particular cost does not go on the final device. What the user would have to pay would pretty much be close to the bill of materials, the cost which is required to make the device. So that is one key thought what we take to make the devices more affordable. And talking more particularly about Indian context, I see the big challenge being that the market, even though it's a very big market, I remember a couple of years ago, there were over 3 lakh wheelchairs sold in just a single year. But the problem is that it's a very fragmented market. Like if anyone has to reach out to a lot of these users, there is no single channel, or there are no few channels with which you can reach out to the users. Because it's such a broken system, it's very difficult for someone to really understand who the users are and build quality products for them. So that's one aspect which really limits. Generally we see that a lot of development often happens whenever there is a good market potential. That's like a basic human factor. Whichever industries have grown well are the ones which have big market. Now even though over here the market is big, if somehow we can put all of the different people who need assistive devices together, that forms a good panel, and that will attract a lot more interest into the device development. Yeah, those are some initial thoughts. Yeah.
So I have one more specific question for you, Vivek. Uh, how do you think principles of universal design affect your thinking when you start designing a new product?
Right. Yeah, especially one of the things what we get to learn a lot when we are designing a device like a wheelchair or any other assistive device, because these products are very close to the user. It's not like we are designing a car, scooter, or anything where there is a limited amount of interaction between the device and the user. With these devices there is a significant amount of usage and significant amount of even connection between the device and the user. So that is where I see in this field there is no other way to design except using user centric design. You have to take all your decisions keeping users interest at the very core. So, how we do that, particularly talking about Arise wheelchair development, during the development of that, we had pretty much traveled across the country, met over, I had personally met over 500 wheelchair users and spoken to them about what they feel, what they think, make them use the device and really see which aspects of the device are they able to use very comfortably and which are the areas of improvement. So being closely involved with the user, especially in this field, is uh, is the only way I feel for developing assistive devices.
That was very enlightening, Vivek. As a wheelchair user myself, I have to thank you for the role you played in bringing about the low-cost wheelchair uh, and neo motion. And I also greatly admire the way you have gathered valuable and immense wealth of experience by doing user interviews. That is amazing. Like usually, yeah. When designing assistive tech, engineers find the problem, try to solve it, and then give it to users. So you did it the right way, and thank you very much for that. Um, so our next speaker is a good friend of mine, and in fact, he was my occupational therapist, and he was the one who recommended my first wheelchair. So let me introduce you to Samson Daniel. Uh, so, Mr. Samson Daniel is an occupational therapist who has worked at CMC Vellore for over 8 years, and he has a Bachelor of Occupational Therapy from SRM University. He currently leads the clinical team at TTK Center for Rehabilitation Research and Device Development at IIT Madras. Samson has been named the user champion for NeoMotion assistive solutions for 3 years and has clinical research interests in hand function, wheelchair mobility, and technological interventions in rehabilitation. So, Samson, this is my question for you. So you are an OT who is currently involved heavily in designing and testing of assistive technology. But as an OT, uh, how did you, before you started involving yourself in the design process, how did you try and bridge the gap between what was available and what the patient needed? And how has this experience influenced your core principles of design when you attempt designing a new product or evaluating a new product currently?
Thank you, Shashank. Am I audible?
Yes, Samson, you're audible.
Okay. I think this is an interesting question. My interest or kind of my contribution into design of assistive technology started from my undergraduate times, where I spent more time in the workshop or the place where devices are manufactured, observing them and seeing how they could be useful, compared to the time spent I spent in classrooms or lecture halls. So same thing was carried out to when I was working with CMC Vellore. I get a lot of complaints from other therapists that I leave my patients in the therapy hall and then I go sit in the workshop or the P intersection. And what I actually got is, rather than leaving the non-availability of devices or suboptimal devices to for the patients to choose themselves, I can make a difference by kind of using whatever knowledge I have from my skill and experience as a therapist, from my information I get from the information I gathered from the patients, and from my knowledge on the Indian requirements. Like, the durability has to be better. The way people use things is different here compared to Western countries, and their likes are different here compared to someone coming from a different cultural scenario. So having those in the back of my mind, I go all out. Like, I go total custom for making a lot of devices, and there were a lot of very interested chaps along with me when I was working, the students, colleagues, and they offered help. And I always involve the patient and their family along with me while doing these things. First thing which goes into action is I keep observing. I compare the differences between like a requirement. Like my most like I commonly work with persons with lesser hand function. Like, most of my work in terms of technology has gone into that. On random Saturday, to give an example, on a random Saturday afternoon, I will call two patients, one a paraplegic, one a tetraplegic, and then kind of observe the hands, see how it's working. This was in the initial days of my work at CMC Vellore. And oftentimes, I think friends will make fun of me, saying, "Why are you having that person's hand in front of you and make loving that hand?" Such kind of thing. So I kind of think biomechanically, functionally, and see what outcome is required, and how do we achieve that outcome with what we have, and what materials we have, which will be acceptable for the patients to use. The first thing which I always place in my design, which I learned by my trial and error in my first workplace, is appearance comes first. No one likes to, at least not many, like to take a device which looks complicated or which looks kind of weird or ugly to a school or to a work setting, just because it's functional. So people are entitled to choose an accessory or a device which is just like an accessory. We don't get ugly watches just because we want to see time. We don't we don't tie a sundial in our hands and go to work, right? So appearance has to come first. Next, which comes in my view, is safety. It has to be totally safe, and then comes reliability, and then comes uh, functionality. The functionality will definitely happen because that's what we everyone is most concerned with. But before that, the things which I have in my specific order is appearance, safety, and reliability. So that I picked it up from my initial practice, and my approach was totally taking the patient, taking some insights from them, go and sit on the workshop, try to do things by myself or get advice from a nearby welder outside the institution, go to a carpenter, go to a woodworker, anyone. My goal was to make it feasible. And one important thing with that approach was I learned it from the patients themselves. They were very good teachers. Like they will give me cues about what they want and what they have done. So from what they have achieved a little, I picked it up from there and made it a very kind of complete solution for that. And that's what I would like to give us a response. Did I make sense, Prashant?
Yes, absolutely, and like that is very insightful. It made me flash back to the pile of assistive devices that I have rejected myself, and I didn't think I would care about appearance as much, but I realized that most of the assistive tech that I've rejected because of appearance, not because of functionality. And being an engineer, I always think functionality, form follows function. But in case of assistive technology, I guess it's the other way around. Function follows form. And uh, I also appreciate you leading the charge alone on user-centric design when it comes to assistive technology, way before everyone else in this panel, I guess. So, like, thank you very much for that. Uh, so now I have a question for our next panelist. So our next panelist is quite famous, and it is almost impossible to talk about the assistive tech landscape in India without his name coming up. Um, Let me introduce you to Professor Shivakumar Balasubramanian. Dr. Shivakumar Balasubramanian is a professor and HOD of bioengineering at CMC Vellore. He has a BTech in Electronics and Communication Engineering from Pondicherry Engineering College and a master's degree in biomedical engineering from IIT Bombay. He received his PhD from Arizona State University in 2009, specializing in rehabilitation robotics for the upper limb. Dr. Balasubramanian was the postdoctoral research associate at Imperial College London from 2010 to 2012. He has worked as a researcher at Technalia Research and Innovation from 2012 to 2014 before joining the Department of Bioengineering at CMC Vellore. He currently leads the Biological Learning and Rehabilitation Group at the department, which focuses on translatable tools for neurorehabilitation and quantitative methods for movement assessment. So, it's an absolute honor to meet you for the first time, Professor Balasubramanian. And this is my question for you. Um, so there is certainly a need and a definite interest for developing adaptive physical therapy equipment. And as a quadriplegic myself, I can definitely attest to that fact. Your extensive research in this field makes you very uniquely qualified to answer this question. What is the likelihood of developing an exoskeleton arm that can be used to rehabilitate small muscles and hands? And again, this is probably a quite selfish question because I'm a quadriplegic and I struggle with my fine motor skills like writing and typing. And what are the technological and economic barriers in realizing such a product, like, at least until the prototype stage?
Hello. Eh, Am I audible?
Yes.
Yeah. Okay. All right. Thank you very much, Shashank, for that introduction, and I thank the Spinal Foundation and Justin for the invite. Regarding your question, right? Is your question specifically for fine motor function for the for improving fine motor function of the hand, or hand function in general?
Yeah, hand function in general. My personal interest, I guess, is in fine motor
Sure.
skills.
Okay. See, and your question also specifically referred to exoskeleton. So, should I specifically just look at the exoskeleton, or do you want me to talk about hand rehab in general?
Please, this is an open-ended question, so
Okay.
it's all up to you. Like,
All right.
I
Okay. So
needed a way into, dive deeper into your research, and this is the in I found. So,
sure. Okay. All right.
please
Got it.
feel free.
Sure. See, hand again, when we are talking about, let's say, hand rehab or rehabilitating hand function, as you know, hand is a very complicated organ. There are lots of things that we do. So when you look at conventional therapy also, the kind of movements and tasks that patients would have to train to recover hand function would be numerous. So you train on different things for the wrist, maybe some pronation supination, maybe some gross hand opening and closing, and maybe then some fine grip function, and maybe also finger individuation. So I would say there is a range of tasks that a range of activities or movements that you would have to train on as part of any rehab for the hand. Now, talking about technology for hand rehab, again, this would mean since there is really a spectrum of activities that you have to train on, it would mean that technology that you develop should be able to support all this. And I don't think there is one technology that fits all of this. So I don't think there is one size fits all solution here. In terms of technology for movement training, I would say that there is really lots of different technologies, and each one is specifically suited for a particular type of patients or a particular application. So that could include robots, some sort of sensorized devices, objects that have sensors in them so that you can interact with your hand. You can have systems that use cameras that track your movements and then give you feedback. And of course, you also have electrical stimulation and other things. And I would say all of these have a role to play. And which technology you choose would depend on the pros and cons of the different technologies and the unique features they offer. Since you asked about exoskeleton, maybe I'll talk a little bit about robots, because we also do some work for robots for hand rehabilitation in my group, along with Dr. Sujata's group in R2D2. So again, when we talk about robots for the hand, right? Because I said you have to train a lot of different things with the hand. It means the robot that you develop would have to be able to support all these different functions, or you would have to have a set of robots that cover all these different functions. And from my own experience of having looked at the development of rehab robots in the last maybe 15 years, I would say robots are a suitable solution only for a specific segment of patients who would benefit from some sort of physical assistance from an external device. For example, if you have somebody who already has some residual function, you don't necessarily need a robot for them. I mean, coming back to your specific question of fine motor function, I don't think you need a robot for training somebody whose focus is on fine motor function. You would be better off using some sort of a sensor-based device, which would be simpler and maybe more suited and easier to develop also. But robots, I would say, are more suited for people with lower function or more impairments, who have a lot of difficulty in making even simple movements. For them, having a device that assists them to move makes sense, because if you can move very little, there isn't much motivation for you to move. But if you have a robot that helps you move, then maybe you are now motivated to train with the robot, because now you are able to make larger movements that you would not be able to do otherwise. I don't think it is an exoskeleton would be a suitable solution for fine motor function. And exoskeletons are just one type of robotic solutions. There are other types as well, which I think are more or less complex and maybe more affordable from a product perspective. In general, what I've found is exoskeleton robots tend to be more complicated from the engineering side and also expensive. So I don't think they would you could come up with realistic products for our scenario in India for hand rehabilitation. But you could develop other simplified devices that can still do this job, which is part of some of the work that we currently do.
Thank you, Professor Balsubramanian. That was very insightful. And to be honest, I have a couple of more questions that I was hoping I could ask everyone who's part of the panel. So this question goes for everyone. Once again, since we are already talking about exoskeletons, let's talk about exoskeletons for walking. What do you think is, how practical do you think exoskeletons are for enabling walking function in paraplegics and quadriplegics. And I was hoping maybe Professor Shivakumar could talk about the viability of actually building a prototype, and Samson could talk about rehabilitating someone and enabling them to use that particular device, and Vivek could talk about maybe what problems we could face in making it more economic and taking it to the market in India. So
Sure.
shall we start with Professor Shivkumar?
Are you specifically asking for training purposes or for assistive purposes?
No, I was hoping we could talk about exoskeleton for the lower part of the body, and as a daily driving functional device. So something that
For
I can put on in the morning and go about my day.
Okay. See, I mean, you can develop it, right? Because people have already done that. So there are some commercial devices that are available. I don't do much assistive work, so my answers might not be completely correct. I think people from RTD2 would have a better idea about this than me. I mean, it is feasible, right? You can develop something like this, but again, we have to look at whether that is something that is realistic as a product for paraplegic users to use in our country, because I don't see a lot of them using it even in the Western countries, and I'm sure they're prohibitively expensive. Um, I mean, if you're looking let's say 10 or 15 years down the line, where maybe these things would become realistic because some of the associated technology is cheaper and all that, and they're a little bit more useful, then again, you'll have to think about issues like safety, right? I mean, especially with assistive devices for walking and stuff, safety becomes a major issue because you only have to have one fall before the product gets a lot of bad name, and then you have difficulty getting it through.
Samson, would you be able to give us an idea of what you think about walking devices in the form of exoskeletons?
Yes. When we think about walking devices as an assistive, assistive exoskeleton, what I would like to see first. So now, when I'm going to switch my hat to the users or the therapist side rather than being on assistive technology side. If I was thinking of prescribing such a device or helping a patient acquire such a device, what I will first see about how reliable it will be. Expense is going to come down after a while. The patient may be able to afford it with self-funding or some other funding, or they can even loan it for a certain amount of time just to get that experience. What I would like to see is the reliability. I have not had a personal experience with the exoskeleton or any other walking device as of now, but I've heard some, I've seen some, not touched and used it, but heard and seen in person. It has to be reliable. Like, take wheelchairs, for example, everyday mobility. We don't have a wheelchair clinic in a major city in India. Like, people have trouble for basic mobility just to get a tire filled with the proper air pressure. It's very, very simple thing. Uh, Forget wheelchairs. Think about regular vehicles which do we get adequate service? So when it comes to a very complex or very important or very expensive or a very meaningful device like an exoskeleton, what I would like to see first is it has to be a daily driver, as you said. It has to be reliable. If you mean daily driver, the person who is going to be using it has to rely on it. It should not go wrong. It cannot go wrong. That is the first thing which I will see. It may be feasible in the future. If we have to step into the shoes of the users, we'll have to think about reliability first and then work around the other stuff. There may be features, there may be a device with less number of features, or maybe something else. The weight can be more or something else, but it has to be reliable first. We'll have to have people using them. We'll have to have people functioning in them as every day, even for 5 steps in the house. Then we'll get a lot of inputs to work on the other stuff. It has to be usable. It should not be lying in the shelf, and it has to be accessible to all. That's what I will say.
Sure, yeah. I'll
So
take the.
please give me a second, Vivek. I just wanted
Yeah.
to ask everyone to kindly post their questions in the chat since we are almost nearing the end of the discussion and you have pretty much heard, you know about all our panelists. Feel free to shoot questions at them. I'll do my best to pick them out and ask them at the end of the discussion. Thank you. So Vivek, if you are able to, so if the product finally is able to jump through the hoops presented by Professor Shivkumar and Samson, what do you think would be the difficulties one would face in taking such a product to market and making it actually economically viable?
Sure, yeah. First, I think I'll just go over the point of safety. It's like I'm very hopeful about technology. Like if you look in 1900s, no, there was no one who was flying. Then the safety rate at that point of time was very low. But presently, the safety rate of a device which is flying is extremely high. It's very safe to go in any aircraft right now. So it is something which will definitely come up with time. Even right now, we implant devices into the human to replace organs. We've reached that level. So I'm very hopeful about the safety side. We'll definitely get there. Painting a picture of the present situation, I don't think there is any device in the world so far which can be used throughout the day. Even though there are many exoskeletons, but the power backup what they have will last only for a couple of hours, and even the distance of commute which is possible is not more than a couple of kilometers at the best. So we are presently in that range. We are in the initial leg of the technology, and the prices are also exorbitant. If I'm right, they cost anything in the order of 50 lakh rupees and more than that. It goes up to a few crores depending upon the specification. So that is the situation we are in right now. And painting the picture of the future, going around 20-25 years down the line, we are changing right now presently faster than any time previously. So there will definitely come a time when these devices like our mobile phone will become very common, very safe, even to a point where it will become affordable, because affordability will come with the quantity. Only when a lot of people have started to use a device, because the production, all of the process tooling, all of that will come much more affordable with quantity. So when we, to reduce the cost, one is, once a lot of people start adopting the device, definitely the cost comes down. And also with all the regulations aspect, a lot of initial hurdles are there, but once all of that is through and the product is more stable and users really find it changing their life, yeah, the cost, because more and more users will start adapting it, the cost will keep coming down. Yeah, that, those are some initial thoughts. Yeah.
Now, since I think we have a little time, I was saving this as a bonus question for Professor Shivkumar in case we have any time left over. So, Professor Shivkumar, could you comment on the viability of implants that might be able to bypass the level of injury or the injury in the spinal cord itself in order to more like resume the continuity of the spinal cord and make uh, make the spinal cord essentially functional again. It's not limited to just this version of the implants alone. What do you think about implants which are closer to the periphery, like implants in the major muscle groups, which are able to stimulate the muscles and then control them? Uh, what do you think is the viability of that technology, and where are we currently, and how long that might take to come to market, and is that safe in the first place? You're on mute, Professor Shivkumar.
Yeah, all right. Yeah, so I know a little bit about the work that's done for the periphery in terms of implanted systems for basically controlling your muscles, some sort of an implantable FES system. Uh, There was a lot of work on this, maybe in the 90s, and some work maybe in the early 2000s. But right now there isn't much. I think my understanding of it is. These were quite expensive. So, of course, whenever you have an implanted system, there is a lot of things you have to consider in terms of the operation, the biocompatibility of the devices, how long can these devices function properly within the body, and all that. Right. So those issues exist. There are some, for example, for simpler functions like, let's say, drop foot correction. Right. There are commercial products that are available. Again, I'm not sure how well these systems sell compared to, let's say, a surface FES system compared to an implantable FES system for drop foot. And whether or not these things will start appearing more in the future, I don't know. I mean, FES is an area that we've been working on for a long time, maybe like 50 years, and we still don't have a lot of commercial devices that people are using. You don't see a lot of them using FES devices and walking around, or for their hand as well. Even though there are some commercial products that are currently available, and I have not followed this literature a lot last few years. So I don't know if there is a lot of. I don't think there is a lot of work that's going on in this area right now. There is a lot of work on implanting stuff in the brain directly in the cortex and recording signals and using that for controlling external devices. Again, Neuralink is an example of a company that's doing it now. That's become very popular. So cortical implants, maybe they will cortical implants controlling external assistive devices might start coming up maybe in a decade or so. I might be wrong. But again, it might take a couple of decades before I think these things are things that we see commonly, or even longer. And in terms of peripheral systems that are implanted, like an implantable FES system, I'm not sure there is much work going on right now, and I'm not sure about if we will see a commercial device for such an application.
Thank you, Professor Shivakumar. So this next question is addressed to all the panelists. What do you think we as members of the spinal cord injury community and the government can do to improve funding in the assistive technology space and investment in assistive technology space? So, Vivek, would you like to take that?
Sure. I'll start off. I think always in terms of funding, the point is about the market space. I'm sure that there is a overall assistive device market is a very big market in India. Like what I had told earlier, I remember it was around 2015, 16, something around that, where over 3 lakh wheelchairs were sold in just a single year. So the market is definitely there. But the problem is definitely that it is a very fragmented market. There is no one single place where we can go and reach out to this base. Even like the statistics are that there are 1% of any population is people with disability. I think WHO says that. So there are so many people who are there. It's a very big market. But the problem is, how do you reach out to these people? There is no network. This person could be anywhere in the village, totally disconnected from the community, and there are many people like that. Even when we were visiting fields for development of our eyes, I had met people who were just in their home for over 10 years, who were just on their bed. So because the users do not come out as a collective unit, I see that as one big challenge. Once we have collective entity, that definitely plays a stronger voice to pitch in this point. And second thing also generally is that in this space, the paying capacity of the customers is generally low. It's a donation driven market. So what happens is most of the users who get the wheelchair will get it for very low or no cost, and they cannot demand for a quality product from these users, from whomever they are buying it. So that's always limiting. Only when users really shout out at the manufacturers, that is when the quality really improves fast. Yeah, those are some thoughts. Yeah.
Samson, would you like to answer the question? Uh,
Okay.
Thank you.
Yes,
Is it-
Shashank. So I really don't have much on this note, Shashank.
Okay. Thank you, Samson. Professor Shivkumar, would you be able to give us any insight into how we might be able to improve funding in an investment in assistive technology?
See, I think Vivek made a couple of very relevant points. I think if we are talking about funding from the government, then I think the researchers that are working in this area and maybe NGOs like the Spinal Foundation and people like Justin, maybe we have to try and make an argument to the funding agencies saying that we should have maybe regular calls on assistive technology. But I'm sure there are avenues already for something like this. I can't remember the name of this funding scheme, but there is one for rehab for sure. Either from, I think it's from DST. So that's one possibility. I think as researchers, I think we have to voice our opinion to the funding agencies, asking them to put in a bit more resources into this area if we are to improve the assistive technology and rehab landscape within the country. In terms of other funding sources coming from private players, that I'm not sure. I think Justin might be able to answer that a little better than I can.
So, Justin, would you like to answer that?
Sure.
We're
So,
here.
yeah, Shashank, in my opinion, I think the very first thing that needs to happen is India needs to have an assistive technology policy. A lot of countries are working on it. Some countries have that. It is WHO's mandate to have a well-defined assistive technology policy. So India needs to define that, and in that, along with that, they have to define what portion of the budget would actually go where in terms of development. That's one. Two, what a country could do is, as part of CSRs, they could earmark a certain portion for technology development fund. They could create a fund that way. CSRs contribute for a particular specific cause, and for that they can earmark certain organizations, saying that your fund is going to go here, and this is the meaningful translation that will happen for your fund, so that it has an impact in this particular population. I think that way. In the next 5 years, we would see funds really pouring in for some groundbreaking technology. I'd also like to, kind of go back on some of your questions. I think this panel broke a lot of hearts when we said, exoskeleton not happening anytime soon. But that said, I also want to impress upon the fact that uh, as a user myself, as a quadriplegic, as a person who is working in an NGO space with the Spinal Foundation, and also as a person who's closely associated with assistive technology through R2D2. So I wear all these three hats, right? I think there needs to be, for any technology, an inflection point. If you're not reaching that inflection point, and if you're trying to, come up with anything before that, you are not going to cater to the masses. There is products and technologies and science that can give you hope, and then there are products and technologies and science that can give you hype. For example, 11 years back when I was injured, there was a lot of hype about stem cell therapy, right? And I thought, okay, in the next 3 years, 5 years, something's going to happen. And 10 years down, it's the same. And I research and I see for the last 30 years, that's what has been going on, right? In pockets, some people say stem cell therapy and all that stuff. But you look at the result, you look at the science for spinal cord injury. I think there's not much that has been achieved through stem cell therapy. So that's hype. The research should still go on, right? We should not stop that research. But there's going to be an inflection point probably in the future. So the research should continue, but practically it's not possible. Similarly, for exoskeleton, you're talking about a technology that's about $100,000 in the US, where a lot of US users are not able to afford it. Even if you bring it for 2 lakhs or 1 lakh in India, how many people can really afford it? Because we have a wheelchair, a lightweight active wheelchair, that's for about 36,000 rupees, that's sold in India for the first time in India. An active wheelchair. How many are able to afford it? You're talking about 50 numbers being sold in a month, or about 300 to 500 sold in a year. So would you like to, do something that actually caters to the masses, a lot of people, or work on something that actually caters to 10 people, right? The research should still go on. Maybe 10 years down, it is available for the masses. But right now, probably we are not there. And I think we should change our thinking. And I've seen a lot of people, right? For example, the rewalk that you're talking about, the exoskeleton that you're talking about in US, if I use a wheelchair, I can go faster than them. I can zip fast. Even a person without exoskeleton, without disability, if they're walking, I can go faster than them, right? So the quality of life is very important, and the assistive technology and the devices that you use to enhance the quality of life is very important, and therefore users should merge the quality of life along with their felt needs, not just wishful thinking, but practically what you should do to move on. And I've heard a lot of arguments coming from a lot of people saying, hey, an exoskeleton can help you in standing, it can help you in therefore blood circulation, osteoporosis, and things like that. I've had the spinal cord injury as a quadriplegic for the last 11 years, and I'm living a fantastic life. Why? Because I can swim. Swimming, getting an access to membership for swimming, or pushing the wheelchair every day in the morning using a gripped glove without using fingers, has the same effect. My bowel management is fine, my bladder management is fine, because I'm so super active. I think assistive technology, the goal of assistive technology should be to enhance quality of living, and if you're able to achieve that, I think we are taking care of a lot of things. And I think users also have to be realistic in that. But going back to the panelists and people working in the assistive technology space, what's important is not manufacturing or creating world class devices, but devices that are actually useful for the users. I know, I'm pretty sure, with all the engineering capability, we can put excellent, extraordinary devices. But if they're not useful for the users, I don't think we are moving anywhere. So the design needs to really, as Vivek said, has to start from the user. The problem statements have to be validated by the users, and we have to go through multiple trials. And I think with that, I'll pass it on back to you.
So that is very well put, Justin. Very eloquent and very apt. And I that was a very satisfying answer to the question. So since you brought up you and almost all the other panelists have brought up voices of the users and the user experience, let us go for some Q&A from the audience. So the first question is it's actually open to everyone, and it's more like an accusation. Joginder Singh says, "Is there any development in getting active lightweight wheelchair made of titanium? Why are we not able to manufacture it in India? Importing it is very expensive." And I share his sentiment, along with probably almost every quadriplegic in India. So this is for all of you guys. Why? You are the guys. You are the ones leading the charge here. So why don't we have a titanium wheelchair?
Yeah.
I think I'll go first.
Yeah.
So we need the answer to why is we need more people like Joginder and Shashank asking for that. So when people feel the need to invest in, not buy, invest in such a kind of a technology or the solution, uh, and the therapist also recommend and feel the, or the rehabilitation professional also recommend and feel the importance of using such a device, which enables the person to resume their activities which they were doing pre the paralysis, before the paralysis, then a lot of availability will start. A lot of devices will start becoming available. It may not be it need not be specifically to a titanium lightweight devices. A lot of other devices. I think we need a lot of takers. We need early adopters, and we need people to be aware. We need the community to be aware and kind of realize the importance of such a device. We need more people like you and Joginder. Thank you.
Yeah, I think pretty much that is what I was also thinking about. That more and more people, once they start raising their voice, that is when change can happen on that. Also pointing out presently, if we see, uh, even if I say 1%, that will be exaggeration of people who use any form of a decent wheelchair. Most of the wheelchairs, like what we know, are not something what Samson would prescribe to people, because there's no adjustment. The posture is very bad. They are big, bulky. So we are presently, if you look at the landscape right now, we are far back. That's the reality. and only when a lot of people will start making a move, a lot of support is required on that, but only when a lot of people start making a move, we can lift the whole landscape.
Yeah, and just adding to that, right? I'll frame it in a way, and for Joginder as well. See, there is absolute need for these devices, quality devices, lightweight, and all that stuff. But unfortunately, in India, the demand is not there. There is a difference between need and demand. I need it, but the demand happens only if I have the money to do it. And we're talking about two-thirds of Indians with disability don't have livelihood. So even if we create a product for 10,000 rupees, right, for the one third that has a livelihood, it's going to be 1 month's salary, or even more than that. And for the remaining two-thirds, there is absolutely nothing for them to actually shell out, and the family is tired and worn out. And for a person with spinal cord injury, we're talking about first their surgery cost, then their lifetime rehabilitation or physiotherapy cost, and they are spent. They don't have the money for it, and therefore the demand is not created. And usually, what happens with CSRs or government giveaways is they try to focus on quantity over quality, and they just want to find out the cheapest possible thing, and doesn't matter what the user needs. And oftentimes we see a device that is not needed for the person is pushed onto their throat and given to them, right? And people just get it, and it just stays at their home. So I think that scenario needs to change, and as all of these keep changing, somewhere in the future we'll get there.
So even the next question is, I would say, more of an accusation on the similar lines. Uh, so we have questions about people asking about wheelchair accessible cars, and why don't we have wheelchair accessible cars in India? So any takers? Maybe Justin.
We do have wheelchair accessible cars, right? I mean, you'll have to just get, if it's an automatic car, we are talking about a 10,000 to 15,000 rupees conversion kit. If you have a geared vehicle, we are talking about around 50,000 rupees to make an auto clutch, and it's a simple mechanism. As a quadriplegic, I drive push and pull mechanism. So you push its brake and pull its accelerator. But if you're talking about your wheelchair getting into the car, or this seat swelling outside, we can do that. There are people who do that as well. But here's my suggestion: get a good transfer board, learn a transfer technique. You're giving workout for your muscles, you're keeping yourself active, move on. Don't expect everything to be aided and spoon fed. I hope I'm answering the right way. As an occupational therapist, Samson, I think you can chip in and answer that as well.
I was about to say the same thing, Justin. So, practical difficulties apart, so wheelchair which needs to go into vehicle will need a bulky vehicle, given the traffic conditions in many places in India, and the difficulty of a person to kind of navigate the traffic. A big vehicle uh, may not be very practical. So I think the question was addressed in that way. Uh, Possibility of like availability of a wheelchair going into a big vehicle. So we need multiple solutions. Once people try a particular solution, try the transfer technique for 3 days, and then probably take a choice. And that is doable. The wheelchair going into a vehicle is doable. I've seen some people use that.
So maybe if we put our heads together, we can create a common solution for multiple vehicles, and we can create maybe a choice of products wherein we have different ways to operate the hand controls, and we can probably make it all available and through one portal, so that you don't have to find someone. Maybe you don't have to involve yourself in the design process. Someone who's approved and experienced can come to you, install it, and then go away. So maybe that could be something we could look into. And with that, we are.
Shashank, with your permission, is it okay if I ask a question to Professor Shivakumar? If
Yes, absolutely, absolutely.
Professor Shiva, are you there?
Yeah, I'm here.
So something that I've noticed is the quality of rehabilitation depends on the quality of the therapist, right? And I've seen in one center somebody doing really very well, even if they are tetraplegic. and some other center, even if they're paraplegic, they've not learned it, right? How can we standardize this with the use of rehabilitation devices? And how soon can we, look at something that kind of creates a standardization across all boards and gets the right data, so that it's where the therapist can just sit back and analyze a lot of things. I think a lot of therapy is not analyzed really well. uh,
Agree.
there is a big gap there, and the standardization is simply isn't there. It should not be a person dependent process here. I think there could be some standardization by the involvement of devices. Would you agree? If so, what are your ideas and thoughts for the audience?
Sure. I think that's a very relevant question. See, my work is mostly in stroke, but we see the same problem there. A lot of therapy, understandably, because it's a very complicated problem, is a lot of art. Therapists make decisions on what they observe, what they know from their theory, and what they've experienced, and what the patient wants and needs. So it's really very complex. So that will obviously play into some person recovering better, some person not recovering better. And again, the knowledge and the understanding of the therapist also plays an important role, along with the residual capacity that the person has. So, for example, you and I might have the same level of injury, let's say a spinal cord injury that looks the same, maybe in our imaging results, but our recovery patterns might be very different because it depends on a lot of other things that we might not directly measure. So at least in the stroke literature, there is now a lot of talk about, of course, doing a lot of measurement that will help us stratify who will improve how much, or at least being able to channel them through the right therapeutic channels so that we maximize their recovery. So that work is happening, but the only issue is, see, it will take some time, because this is again for something to be accepted in the clinical practice community. It has to go through a rigorous process of being validated, saying this does have, this particular channel for these subgroup of patients does work. Work is going on, but I think it will take a little bit of time. To come back to your question, technology, of course, can play a big role here, because it will allow us to measure a lot of things that don't get measured in this process. For example, we still don't actually. So I go. Let's say I'm a patient. I go for therapy. I do 1 hour of therapy. Let's say every day for 4 weeks. But there is no record keeping of what movements were done, how long were these movements performed, how many repetitions were performed, how much time did I take rest between my movements during therapy, and all that is not recorded right now. And all this is relevant because the kind of activities you do during therapy will have an impact on what functions you recover later on. So the availability of rehab devices will make measuring some of these things possible. Robots, wearable sensors, cameras, and all that. Right? So once we are able to have these devices and measure them, then possibly we can see patterns of people behaving differently, because some of the therapeutic variables are now being captured. So there is, of course, this is all also very a lot of interest to the academic community. So there are people trying to do all that now. See, one example is, at least in the stroke community, is so they've got, there is this recent product which basically looks like a small disc which patients use for training hand function. There was a recent presentation in one of our workshops where they showed that these discs are about $300 US, so they're very cheap, and now they're able to track like 8,000 patients over time who are using this at home. This was never possible before. But because now we have these really nice devices that can measure some information about what you're doing, all that is becoming possible. So there is a lot of work going on. Technology will definitely help us capture these variables and maybe build models that will tell us who needs to go where. And then we can then start talking about standardizing stuff, because based on my behavior, then there is a standard for what route, therapeutic route should be taken for maximizing this person's recovery. I would say maybe in the next 5 to 10 years, we'll at least have some good results from the academic community, which then maybe will translate to companies that are developing products and stuff who will incorporate these elements into their products, and maybe then we will start talking about as a community about standards.
Thank you so much. Yeah.
Okay. So, any other questions you want to ask the panel, Justin?
No, I'm good with questions. So if you're done, we can close the session.
Okay, so on that note, with the rosy outlook of the future, I'd like to thank everyone for attending the session. Thanks for putting up with all of us, and thanks especially to everyone on the panel who patiently answered all of my questions, and to the audience who patiently listened and um, tried to participate. Thank you very much for all that, and I hope you have a very great evening ahead of you today. I'm handing the baton over to Justin. Thank you, Justin.
Right. Thank you, Shashank, and thank you, Professor Shiva, Samson, and Vivek. Fantastic evening for us with a lot of insights. Really appreciate for taking the time off. That said, to the audience, I think nobody more than Shashank or I would love to have an exoskeleton that walks and helps us move around just like anybody else without disability. And nobody would appreciate if stem cell therapy actually has effect and makes us like we were before our injuries. So we absolutely appreciate that. But that said, currently we are not there yet. Uh, Alternative therapies, no scientific facts that actually say that they are producing results. That said, while we hope in the future we have all these researches actually result into something meaningful, what is really important is to choose the right assistive devices that actually improve the quality of life today, and that's extremely important. There's no point in lying in the bed, being in the confines, saying that I'll walk one day after 10 years, and spending the rest of the 10 years confined in a room. We might as well have the hope is great, but if your hope is blinding you not to move on with your life today and push for quality of life, then I think we are losing a lot of valuable time. So I hope we take all of those meaningful cues from these sessions and move on with our life and push ourselves to independence and excellence in the near future. Thank you so much for a wonderful evening. Have a great rest of the day and rest of the evening. Thank you. Bye bye.
Yeah, thanks, Justin.
Bye bye.
Have a nice evening.
Thank you, Justin. Thank you.
We can stop the recording and stop the live feed, Naveen.